A thyroglossal duct cyst, sometimes just called the thyroglossal cyst, is a congenital disorder where the thyroglossal duct, which is a tiny canal connecting the thyroid gland with the tongue during fetal development, grows in size and fills up with mucus, which forms a cyst. Now, normally during fetal development, a tiny depression called the foramen cecum forms at a spot between the front 2/3 and the back 1/3 of the tongue. The tissue underlying the foramen cecum is different than the rest of the tongue, and its cells develop into the thyroid gland. Through development, the thyroid gland tissue migrates downward as it grows, but it still stays connected by a tiny canal called the thyroglossal duct. The thyroid gland descends down past the base of the tongue and the hyoid bone, which is a small bone present below the chin, before it finally settles down in front of the trachea, in the neck. The walls of the thyroglossal duct are lined by lymphoid cells, as well as epithelial cells which secrete mucus into the cavity. Normally, once the thyroid gland has reached its final resting position, it stretches out a bit and the walls of the thyroglossal duct stick to each other, which obliterates the canal. Over time, the thyroglossal duct starts to disintegrate, and by the 3rd month of fetal development, the duct is usually gone. In some people, though, the thyroglossal duct doesn't close completely, and instead parts of it widen to form pockets, or cysts. The cysts get filled with the mucus secreted by the epithelial cells in its walls. These mucus-filled thyroglossal duct cysts stick around as the fetus develops, and then they can cause a few problems. For example, when there's an infection of the respiratory tract, it can easily spread to the thyroglossal duct cyst, since there are lymphoid, aka immune cells, in the walls of the cyst. Local inflammation also stimulates the epithelial cells of the thyroglossal duct cyst to increase their secretions, and that makes the cyst grow in size. Second, the thyroglossal duct cyst can enlarge to a point where it bursts open, letting the mucus pour out, and that can form a discharging sinus, which is sometimes also referred to as a thyroglossal fistula, even though it's usually not a true fistula. Now, these can also form if the thyroglossal duct cyst is damaged during surgery. Third, in some people, the thyroid gland cells remain within the thyroglossal duct and don't descend down. If that happens, a thyroid gland might not develop normally. And in addition, very rarely a thyroid tumor might develop in the cyst, since there are still thyroid cells in the walls of the cyst. The most common symptom of a thyroglossal duct cyst is painless swelling in front of the neck, which can lie anywhere along the path of the thyroglossal duct. Usually it's midline or just slightly off of the midline, and the most common locations are subhyoid, or just below the hyoid bone, and suprahyoid, just above the hyoid bone. Because of its connection to the tongue, the thyroglossal duct cyst moves up when a person swallows or sticks out their tongue. Also, the cyst might appear red and be painful if the cyst gets infected. The diagnosis of a thyroglossal duct cyst is usually done with an imaging study like an ultrasound or CT scan, and confirmed with fine needle aspiration. Sometimes a thyroid function test is done to assess whether the person has a healthy thyroid gland. Treatment of a thyroglossal duct cyst is surgical removal of the entire thyroglossal tract. In addition, antibiotics might be used to treat infections. Alright, as a quick recap. As the thyroid gland descends during development, a tiny thyroglossal duct forms. If the thyroglossal duct doesn't close in on itself, it can start to fill up with mucus, which creates cysts anywhere along its tract. These cysts are usually midline on the neck, just above or below the hyoid bone, and can be surgically removed. Hey, what's up guys? Thanks for watching that video on thyroglossal duct cysts. If you want to learn more about that topic, you should definitely head over to osmosis.org. We've got a bunch of flashcards and quiz questions and other cool stuff to help you learn medicine. Also, if you want to help support us, you should head over to our shop on osmosis.org. We have some cool new t-shirts in the mix where it says I Osmos Med School. I think they're pretty rad. So if you do want to help support us, you could head over there and pick one up. We also have ones for PA school and dental school and nursing school. So we've got it all. So if you're interested in that and you think this is cool, I would definitely recommend picking one up. So other than that, thanks for watching, and I will see you next time. Bye.
Hyperthyroidism, which is sometimes referred to as thyrotoxicosis, is a condition that's caused by having excess thyroid hormones. Thyroid hormone production is under the control of the hypothalamus and the pituitary. The hypothalamus secretes thyrotropin-releasing hormone, or TRH, which makes the anterior pituitary secrete thyroid-stimulating hormone, or TSH. TSH then binds to TSH receptors, which makes the thyroid secrete thyroxine, or T4, and triiodothyronine, or T3, into the blood. But this is not a one-way street. There's also negative feedback happening, meaning when thyroid hormone levels rise, that inhibits the production of TSH and TRH, halting further production of T3 and T4, and this keeps everything in balance. Normally, some thyroid hormones travel through the bloodstream bound to thyroxine-binding globulin, and some are in their free form. And the thyroid actually makes more T4 than T3, and that T4 is converted to the more potent T3 in the periphery. Thyroid hormones then increase the rate of metabolism in all of our cells, so they make us think, move, and talk faster, and they also increase heat generation. They also activate the sympathetic nervous system, the part of the nervous system responsible for our fight or flight response, increasing cardiac output. Thyroid hormones are important, and the occasional increase is like getting a boost to fight off a zombie or stay warm during a snowstorm. But with hyperthyroidism, it's like the entire body is buzzing at twice the normal rate. So individuals with hyperthyroidism tend to be hyperactive and talk really fast, and present with tremor in the extremities, as if they've had too much coffee. Also, making so much internal heat makes them sweat a lot and uncomfortable in warm temperatures. It can also cause anxiety, irritability, and mood swings, as well as difficulty sleeping. Again, think too much coffee. Hyperthyroidism can also cause an increased appetite, unexplained weight loss, and more frequent bowel movements. On a physical examination, the skin is warm and moist, and their hair is fine and brittle. Classically, individuals have lid retraction, which makes a person look wide-eyed, like the stare of a person who's frozen in fear. Sometimes, pretibial myxedema may be present, which is a waxy, discolored induration of the skin on the interior aspect of the lower legs, with a bumpy feel, like an orange peel. There may be muscle weakness, especially in the thighs and upper arms, as well as exaggerated deep tendon reflexes. Tachycardia, as well as atrial fibrillation, or systolic hypertension, may also be present. Females can have menstrual irregularities, and males can have gynecomastia, or swelling of the breast tissue. However, hyperthyroidism often presents more subtly, with a single symptom evolving over weeks to months, and even that should prompt an evaluation for hyperthyroidism. Now, this evaluation comprises of 2 steps. First, confirming that the individual has hyperthyroidism, and second, finding out why they have hyperthyroidism. The first one's easy. Get serum levels of free T3, T4, and TSH. In hyperthyroidism, either free T3 or free T4, or both, are elevated, and they inhibit TSH, so the majority of the time, TSH is low. Elucidating the cause is the fun part. Pathophysiologically, the causes of hyperthyroidism can be divided into 4 categories. The first is excessive TSH receptor stimulation, and an example of that is Graves' disease, which is an autoimmune condition where thyroid-stimulating immunoglobulins, or TSIs, bind to the TSH receptor and stimulate excess hormone production. Sometimes, this excessive stimulation makes the thyroid gland swell up, causing goiter, but the most characteristic finding in Graves' disease is exophthalmos, which is where the eyes bulge out of their sockets. Exophthalmos is pretty specific for Graves' disease, and classically causes high thyroid hormone levels, low TSH, and a large thyroid without any discernible nodules on palpation. Elevated TSI antibody levels confirms Graves' disease. Finally, if the diagnosis of Graves is unclear, or if there seems to be another cause of hyperthyroidism, the next step is getting a radioactive iodine uptake scan, or RAIU for short. In an RAIU scan, a person is given either a capsule or a liquid that contains the radioactive isotope of iodine, typically iodine-123. Functional thyroid tissue loves iodine and gobbles it up to make thyroid hormones. So, to see how much thyroid tissue is actively making hormones, we perform a scintigraphic scan. The principle is simple. The more active the thyroid is, the more iodine it takes in, and as a result, the more radiation it emits. Then, a gamma camera is used to pick up the emitted radioactive signal, and a computer translates this into pictures with a white background, where the dark areas represent radiation emitted by the functional thyroid tissue. A set of these scans is obtained 4 to 6 hours later, and then another set is obtained 24 hours later. A normal thyroid gland looks like 2 gray wings. With Graves' disease, there's a diffuse increase in the uptake of both lobes of the thyroid, so the thyroid appears darker and larger. If Graves' disease is confirmed, treatment should be initiated with anti-thyroid medication. Enter the thionamides, methimazole, and propylthiouracil, or PTU. Thionamides inhibit the enzyme thyroid peroxidase inside thyroid cells, and that stops thyroid hormone synthesis. For both methimazole and PTU, a high initial dose is used, and then once euthyroid status is achieved, meaning free T3 and T4 levels go back to normal, then a lower daily maintenance dose is used. If individuals have really large goiters that compress nearby structures like the trachea and cause trouble breathing, or the recurrent laryngeal nerve causing hoarseness, surgical removal of the thyroid gland can be performed, and this is called thyroidectomy. Alright then, another cause of excessive TSH receptor stimulation is a TSH-secreting pituitary adenoma, which is when a tumor forms in the pituitary and secretes TSH regardless of any negative feedback signals. In this situation, there are high free T3 and T4 levels, with a diffuse increase in the uptake of both lobes, but with high TSH levels. This is the only exception to the high thyroid hormone's low TSH rule of hyperthyroidism. In this case, a CT or MRI scan of the head is done to identify the adenoma, and then the adenoma is surgically removed through transsphenoidal atomectomy. That's where it's surgically removed through the nose. Talk about tight working quarters. Another cause of excessive stimulation of the TSH receptor is high levels of human chorionic gonadotropin, or HCG. HCG is structurally similar to TSH, so it can bind to the TSH receptor and stimulate it. HCG levels rise normally during the first trimester of pregnancy, and this sometimes results in a transient state of hyperthyroidism that resolves on its own. But other causes of excess HCG are HCG-secreting germ cell tumors of the testicles or ovaries, or a hydatidiform mole, which is an abnormal kind of pregnancy, where the placenta develops with very little fetal tissue and secretes too much HCG, but the fetus isn't viable. Diagnosing germ cell tumors can be done by computer tomography, magnetic resonance imaging, or an ultrasonography of the pelvis in females or the testicles in males. A hydatidiform mole, on the other hand, can occur in pregnant females who have HCG levels much higher than normal for the first trimester of pregnancy. Hyperthyroidism, as well as vaginal bleeding, and hyperemesis, which is extreme nausea and vomiting, are common symptoms. Often, on ultrasound, there are characteristic aspects of the hydatidiform mole, like an intrauterine mass with cysts that looks like a bunch of grapes. Treatment of germ cell tumors and hydatidiform mole, however, is the same, and involves removing either the tumor or the hydatidiform mole. Okay, now the second category of hyperthyroidism is unregulated thyroid hormone secretion, and the key word here is nodules. Basically, either one nodule forms in the thyroid and starts autonomously secreting thyroid hormones. We call this toxic adenoma. Or more nodules sprout in the thyroid and do the same, which is called toxic multinodular goiter. These nodules can be felt on palpation, and on an RAIU scan, the areas with nodules appear darker than the rest of the thyroid. So rather than having a diffuse increase in the iodine uptake, there's heterogeneous increase across both lobes. In other words, some spots in the thyroid gland look darker than other parts. The RAIU scan alone can establish the diagnosis of either toxic adenoma, a single dark spot, or toxic multinodular goiter, multiple dark spots. Easy peasy. And these two conditions are usually treated with radioiodine therapy. The way it works is a person swallows a capsule containing a small dose of iodine 131, which emits radiation. And that's different than the iodine 123 that's used in the RAIU scan. Functional thyroid tissue takes in this iodine just the same, though, and the iodine destroys it with radiation, like a Trojan horse. The person may go home after swallowing the capsule, but shouldn't have prolonged close contact with pregnant women and young children for 3 days, and should drink plenty of fluids so that the iodine is rapidly flushed out of their system. Following radioiodine therapy, hyperthyroidism symptoms usually subside over a few months, and if the symptoms persist 6 months later, a second dose can be given. Finally, surgery can be used to treat large multinodular goiters. Okay, now a third category of hyperthyroidism is because of follicle destruction with release of thyroid hormones due to thyroiditis, or inflammation of the thyroid gland. There's many kinds of thyroiditis, but we'll refer to 2 that can cause hyperthyroidism: Hashimoto's thyroiditis and subacute thyroiditis, which is also called Decker-Van's thyroiditis. Okay, so Hashimoto's is an autoimmune form of thyroiditis, where autoantibodies are directed against the thyroid gland, and, as a consequence, more and more thyroid tissue is destroyed over time, resulting in chronic hypothyroidism. However, during periods of intense destruction, the massive release of thyroid hormones can cause transient hyperthyroidism, a state called hashitoxicosis, a mashup of Hashimoto's and thyrotoxicosis. On an RAIU scan, both Hashimoto's and subacute thyroiditis will present with a near-absent radioiodine uptake, meaning less than a healthy person would have, and translating as a pale thyroid. Subacute thyroiditis may also present with additional clinical findings, like a painful thyroid, as well as flu-like symptoms like high fever and muscle aches, which are not usually seen in Hashimoto's. Additionally, with subacute thyroiditis, there may be a high erythrocyte sedimentation rate, or ESR, typically in the range of 60 to 100. In Hashimoto's, there are usually high levels of anti-thyroperoxidase, or anti-TPO antibodies in the serum. Thyroiditis requires fairly unique treatment. Hashimoto's thyroiditis often requires beta blockers, like propranolol, to control the transient cardiac symptoms of hyperthyroidism. Hyperthyroidism due to subacute thyroiditis often subsides on its own over time, so medication like aspirin, nonsteroidal anti-inflammatories, or selective COX-2 inhibitors are used to help with pain and inflammation. For more severe pain, glucocorticoids like prednisone can be used. A final category of hyperthyroidism is having excess extrathyroid sources of thyroid hormone, including iatrogenic causes, like hypothyroid individuals who are treated with too much thyroid hormone, in which case treatment is adjusting the doses. It also includes factitious hyperthyroidism, which is when a person self-administers thyroid hormones without being hypothyroid, and people might do this when they want to lose weight. In fact, some supplements for weight loss contain thyroid hormones. Treatment is also fairly intuitive, stopping the thyroid hormones or supplements. Finally, and here's one for your hangman games, there's struma ovarii. Struma ovarii is a teratoma made up of mostly thyroid tissue that grows on the ovaries and secretes thyroid hormones. Yikes. Struma ovarii can be diagnosed with an ultrasound of the ovaries, a CT, or an MRI scan of the pelvis. An RAIU scan of the pelvic region will demonstrate higher iodine uptake in the mass than in the thyroid gland. Treatment is surgical removal of the mass, which should be examined histologically just to confirm the diagnosis. Finally, it's important to discuss thyroid storm, which is also called accelerated hyperthyroidism, like taking a racing car and speeding it up. This can complicate all types of hyperthyroidism, and it's where symptoms become so extreme that they can become life-threatening. High fevers, sweating, an altered mental status, hypotension, and even cardiogenic shock. It's an emergency. The person needs to be wrapped in cooling blankets or given cool IV fluids to bring down their temperature. Then, a beta blocker, like propranolol, can be used to help reduce their heart rate and blood pressure. After that, high doses of methimazole or PTU can be given. Finally, glucocorticosteroids can be given to help reduce the inflammation. With aggressive therapy, the storm usually passes in about 1 or 2 days, and full recovery within a week. Alright, as a quick recap, Hyperthyroidism refers to high circulating thyroid hormones in the blood and typically presents with high free T3 and T4 and low TSH, but TSH may be high in the case of TSH secreting pituitary adenoma. The most common cause is Graves' disease, which may present with exophthalmos, elevated serum TSI antibodies, and a diffuse increase in radioiodine uptake on an RAIU scan. Other common causes are toxic multinodular goiter and toxic adenoma, which may be felt on palpation, and present with focal increased uptake in the thyroid. At the other end of the spectrum, there are the conditions associated with low radioiodine uptake, like thyroiditis and extrathyroid sources of thyroid hormone. Treatment of hyperthyroidism relies on thionomides, radioiodine therapy, and surgery, and stopping thyroid hormone medication or adjusting the doses. Thionomides are recommended in Graves' disease. Radioiodine therapy is recommended for toxic multinodular goiter, toxic adenoma, and struma ovarii. And surgery is usually reserved for patients with Graves' disease or toxic multinodular goiter that have very large goiters, which compress the nearby organs. Finally, thyroid storm is an extreme presentation of hyperthyroidism, which requires immediate treatment with beta blockers, thionomides, and glucocorticoids.
On the endocrinology ward, 2 individuals came in. The first one is 55-year-old Gregor, who came in complaining about weight loss, heat intolerance, chest pain, palpitations, and insomnia. On the clinical examination, he's anxious and restless. He also had warm and moist skin, his eyelids were retracted, and there was exophthalmos of both eyes and tachycardia. The other person is 37-year-old Josie, who migrated to the US from Panama. She came in with similar symptoms as Gregor, but on clinical examination, she also had a goiter. According to her, she recently had a contrast imaging procedure for a different problem. TSH and levels of T3 and T4 were taken for both individuals. Levels of TSH were low, while levels of T3 and T4 were high. Okay, so both individuals had hyperthyroidism. First, a bit of physiology. Normally, the hypothalamus detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone, or TRH, into the hypophyseal portal system. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin, or simply TSH. TSH stimulates the thyroid gland, which is a gland located in the neck. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, a protein found in follicles, into 2 iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released into the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these 2 hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted into T3, and it can exert its effect. T3 speeds up the cell's basal metabolic rate. T3 increases cardiac output, stimulates bone resorption, thinning out the bones, and activates the sympathetic nervous system. Thyroid hormones are also involved in a number of other things, like controlling sebaceous and sweat gland secretions, hair follicle growth, and regulating proteins, as well as mucopolysaccharide synthesis of skin fibroblasts. Now, hyperthyroidism can happen a few different ways, and all of them result in too much thyroid hormone and a hypermetabolic state, where cellular reactions are happening faster than normal. First, hyperthyroidism can be primary, in which case the thyroid gland is the problem, and it's making too many hormones. There are a few specific diseases associated only with hyperthyroidism, but sometimes diseases like thyroiditis, which damages the thyroid and causes hypothyroidism, can cause stored thyroid hormones to leak out, resulting in an initial period of transient hyperthyroidism. Then there's secondary hyperthyroidism, where the problem is increased TSH secretion due to a problem with the pituitary gland, like a rare TSH secreting adenoma. Now let's talk about some of the causes of primary hyperthyroidism. Graves' disease is the most common cause of hyperthyroidism, which can sometimes manifest during periods of stress, like during pregnancy. This is an autoimmune disorder where B cells produce antibodies against several thyroid proteins. The most high-yield autoantibodies you need to remember are thyroid-stimulating immunoglobulins, which are a type of G immunoglobulins that produce a type 2 hypersensitivity reaction. They bind to the TSH receptor on follicular cells and imitate TSH. This results in growth of the thyroid gland and stimulates the follicular cells to produce excess thyroid hormone. Now, these autoantibodies can also cause Graves' ophthalmopathy. These antibodies activate the T cells in the retroorbital space, causing them to secrete cytokines like TNF-alpha and IFN-gamma, which increase fibroblast secretion of glycosaminoglycans, which ultimately increases muscle swelling, muscle inflammation, and increases the adipocyte count, leading to exophthalmos, which is anterior bulging of the eyes. Now, thyroid-stimulating immunoglobulins can also increase the activity of dermal fibroblasts, resulting in pretibial myxedema, which is the classical finding of waxy lesions with non-pitting edema that usually appears first on the lower legs. Now, there's a gene complex involved in the regulation of the immune response, and this is called the human leukocyte antigen system, or HLA system. Interestingly, individuals with Graves' disease often have specific HLA genes such as HLA-DR3 and HLA-B8, which are important clues on your exams. Histology of the thyroid will show tall and crowded follicular epithelial cells with scalloped colloid. Another cause is toxic multinodular goiter, where one or more follicles starts growing bigger and generating lots of thyroid hormones independently of TSH. A high-yield fact is that in about 60% of the cases, this happens due to mutations in the TSH receptors that inappropriately keeps these follicular cells active. On histology, this appears as focal patches of hyperfunctioning cells with a lot of colloid inside. Now, nodules that produce a lot of thyroid hormones are called hot nodules because they show increased activity on radioactive iodine uptake tests. Fortunately, they are rarely malignant. Another high-yield concept is the Yod-Basido phenomenon, or iodine-induced thyrotoxicosis. The Yod-Basido phenomenon is hyperthyroidism that happens shortly after administering iodine, even in the form of iodine IV contrast. The phenomenon does not affect people with normal thyroid function, but will affect individuals that are iodine deficient and have a goiter, or in people with Graves' disease, toxic multinodular goiter, or thyroid adenomas. The key point is that all of these disorders have autonomous thyroid tissue that act independently of TSH regulation. So, when there's extra iodine, it provides more material for thyroid hormone production without negative feedback from decreased TSH. You can think of the Yod-Basido phenomenon as the opposite of the Wolff-Chaikoff effect, where a large increase in iodine actually leads to temporary decrease in thyroid hormone synthesis. Regardless of cause, symptoms of hyperthyroidism are similar, and remember that with hyperthyroidism, everything goes faster. Metabolic findings include heat intolerance, weight loss, and increased sweating, due to an increased basal metabolic rate. The skin can be warm and moist, mostly due to vasodilation and increased sweating. The hair is fine and friable, while at the same time there's onycholysis, where the nails separate from the nail bed. Ocular findings include lid lag or retraction, and this happens due to increased sympathetic stimulation of the levator palpebrae superioris muscle. In Graves' disease, there's also Graves' ophthalmopathy. Finally, long-term hyperthyroidism can increase the risk of bone fractures since T3 increases bone resorption, leading to osteoporosis. Gastrointestinal findings include diarrhea and hyperdefecation due to increased gastrointestinal motility, and the appetite is increased. Musculoskeletal findings include thyrotoxic myopathy, which usually manifests as proximal weakness. But, levels of CK are normal. This probably happens because thyroid hormones interfere with cell metabolism, including muscle cell metabolism. Reproductive findings include oligomenorrhea or amenorrhea, low libido and infertility in females, and gynecomastia in males. One of the mechanisms involved is that with hyperthyroidism, there's also an increase in sex hormone binding globulin, or SHBG, and as a result, levels of total testosterone, dihydrotestosterone, and estradiol are increased, and this can interfere with normal hormonal processes. Regarding menstrual disturbances, the mechanism involved can be that thyroid hormones interfere with GnRH signaling, which in turn affects LH and FSH pulses. Neuropsychiatric findings include hyperactivity, restlessness, anxiety, insomnia, and this is due to increased beta-adrenergic activity. Additionally, reflexes are brisk. Cardiovascular findings include tachycardia, palpitations, dyspnea, arrhythmias, chest pain, and systolic arterial hypertension. And these are all caused by increased activation of beta-adrenergic receptors and increased expression of cardiac sarcolemmal ATPase, which allows the heart to contract faster. There's also decreased expression of phospholambin, which is a protein that regulates the calcium pump in cardiac muscle cells. Okay, finally, let's talk about thyroid storm, which is a rare but life-threatening complication of hyperthyroidism, where the body goes into a state of severe hypermetabolism. This can happen when hyperthyroidism isn't treated or isn't completely under control, and can worsen during acute stress such as infections, trauma, and surgery. All of the normal symptoms of hyperthyroidism become exaggerated, and the individual presents with fever, tachyarrhythmias, agitation, delirium, and even coma. Diagnosing hyperthyroidism is done by measuring blood levels of TSH, T3, and T4. If it's due to a primary cause, TSH will be low, and unbound thyroid hormones will be high. This should be one of the first things you consider when you encounter a hyperthyroid problem on your tests. Once hyperthyroidism is confirmed, a radioactive iodine uptake test and a thyroid scan can help determine the specific cause of the disorder. There's diffuse uptake in Graves' disease, patchy uptake in toxic multinodular goiter centered around each nodule, and decreased uptake in thyroiditis. For secondary causes, if TSH level is normal or high, this points to a pituitary tumor, which can be confirmed with an injection of thyrotropin-releasing hormone. Treatment of hyperthyroidism involves beta blockers like propranolol in order to reduce the effects of thyroid hormones. There's also propylthiouracil, which decreases thyroid hormone synthesis, and corticosteroids like prednisolone to inhibit T4 to T3 conversion. Finally, there's potassium iodide, also called Lugol solution, which can cause decreased thyroid hormone synthesis via the Wolff-Chaikoff effect, and it also decreases vascularization in the thyroid. Propranolol, propylthiouracil, and corticosteroids are all used as first-line treatment of thyroid storm, while Lugol solution is used as a second-line treatment. All right, as a quick recap. Hyperthyroidism can happen a few different ways, and all of them result in too much thyroid hormone and a hypermetabolic state. Symptoms of hyperthyroidism affect multiple systems. Metabolic findings include heat intolerance, weight loss, and increased sweating. Skin and hair findings include warm and moist feel of the skin, fine and friable hair, and onycholysis. Ocular findings include lid lag or retraction. Gastrointestinal findings include diarrhea and increased appetite. Musculoskeletal findings include thyrotoxic myopathy. Reproductive findings include oligomenorrhea or amenorrhea, as well as low libido and infertility in females, and gynecomastia in males. Neuropsychiatric findings include hyperactivity, restlessness, anxiety, insomnia, and brisk reflexes. Cardiovascular findings include tachycardia, palpitations, dyspnea, arrhythmias, chest pain, and systolic arterial hypertension. With primary hyperthyroidism, TSH will be low and unbound thyroid hormones will be high. But with secondary hyperthyroidism, TSH is normal or high. Regarding causes of hyperthyroidism, Graves' disease is the most common. Other causes include toxic multinodular goiter, thyroiditis, and Yod-Basedow phenomenon. A thyroid storm is a rare but life-threatening complication of hyperthyroidism, where the body goes into a state of severe hypermetabolism. Okay, back to our cases. Gregor came in with classic symptoms of hyperthyroidism, like weight loss, heat intolerance, chest pain, palpitations, insomnia, anxiety, restlessness, moist and warm skin, and retracted eyelids. Labs confirm that he's suffering from hyperthyroidism, and the exophthalmos points towards Graves' disease. Josie came in with similar symptoms of hyperthyroidism that were confirmed by lab tests. Given the history of recently having a contrast imaging procedure done, probably with iodine contrast, we can assume that Josie might be iodine deficient, the likely cause of her goiter, and probably suffers from Yod-Basedow phenomenon.
In hyperthyroidism, hyper refers to having too much, and thyroid refers to thyroid hormone. So hyperthyroidism refers to a condition where there's excess thyroid hormones. The condition is also called thyrotoxicosis and is generally due to an overproduction from the thyroid gland. Normally, the hypothalamus, which is located at the base of the brain, detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin, or simply TSH. TSH stimulates the thyroid gland, which is a gland located in the neck that looks like two thumbs hooked together in the shape of a V. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to the circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, where it can exert its effect. T3 speeds up the cell's basal metabolic rate. So as an example, the cell might produce more proteins and burn up more energy in the form of sugars and fats. It's as if the cells are in a bit of a frenzy. T3 increases cardiac output, stimulates bone reabsorption, thinning out the bones, and then activates the sympathetic nervous system, the part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase can be really useful when you need a boost to get through the final rounds of a sporting competition, or when you're trying to stay warm during a snowstorm. Now, hyperthyroidism can happen a few different ways. All of them result in too much thyroid hormone in a hypermetabolic state, where cellular reactions are happening faster than normal. The most common primary cause is Graves' disease, an autoimmune disorder where B cells produce antibodies against several thyroid proteins. These autoantibodies include thyroid-stimulating immunoglobulins, which bind to the TSH receptors on follicular cells and imitate TSH. This results in growth of the thyroid glands and stimulates the follicular cells to produce excess thyroid hormone. Another primary cause is toxic nodular goiter, where one or more follicles starts generating lots of thyroid hormone. In some cases, it's because of a mutated TSH receptor that inappropriately keeps these follicular cells active. A different cause is a hyperfunctioning thyroid adenoma, where the follicular cells start growing uncontrollably, forming a benign tumor that makes excess thyroid hormones. Also, anytime the thyroid gets inflamed or damaged, there can be a large release of preformed thyroid hormones. There's also Jod-Bazadot syndrome, or iodine-induced thyrotoxicosis, which can develop soon after an iodine-deficient person gets a hefty dose of iodine. And finally, neonatal hyperthyroidism, which is when newborns who have a mother with Graves' disease start generating too much thyroid hormone in response to thyroid-stimulating immunoglobulin that crosses the placenta barrier and enters the baby. A secondary cause of hyperthyroidism is when there's a healthy thyroid that generates a lot of thyroid hormone in response to a TSH-secreting tumor in the anterior pituitary. The symptoms of hyperthyroidism include weight loss despite an increase in appetite because of the higher basal metabolic rate, heat intolerance because the body is producing more heat, and rapid heart rate, sweating, hyperactivity, anxiety, and insomnia because of the effects of the thyroid hormones on the sympathetic nervous system. Sympathetic overstimulation of muscles that control eye movements also make the eyes appear more open than normal, so you see more of the whites of the eyes. If the hyperthyroidism has been ongoing for a long time, there is a risk of developing congestive heart failure and osteoporosis. A thyroid storm is a life-threatening complication of hyperthyroidism where the body goes into a state of severe hypermetabolism. It can develop when someone with hyperthyroidism stops their treatment, develops an infection, or has surgery. All the normal symptoms of hyperthyroidism become exaggerated. For example, heat intolerance turns into high fever, and rapid heart rate turns into cardiac arrhythmia. Diagnosing hyperthyroidism is done by measuring blood levels of TSH, T3, and T4. If it's due to a primary cause, TSH will be low and unbound thyroid hormones will be high. Once hyperthyroidism is confirmed, a radioactive iodine uptake test and a thyroid scan help determine the specific cause of the disorder. If blood levels of TSH are normal or high, this points to a pituitary tumor, which can be confirmed with an injection of thyrotropin-releasing hormone. Treatment varies based on the exact cause of hyperthyroidism, but generally involves drugs like beta blockers to treat the immediate symptoms and antithyroid drugs to block thyroid hormone production and release. Radioiodine therapy can be used to partially or completely destroy thyroid function, followed by replacement hormone therapy. In a few cases, the thyroid is removed with surgery. Alright, as a quick recap, hyperthyroidism refers to any one of a number of disorders where there is an excess of thyroid hormones. It is mostly caused by an overfunctioning of the thyroid gland, but is sometimes caused instead by a pituitary tumor or inflammation of the thyroid. The result is a hypermetabolic state, which causes symptoms like weight loss, heat intolerance, rapid heart rate, and hyperactivity.
First described by Irish surgeon Robert James Graves, Graves' disease is an autoimmune disorder that causes hyperthyroidism. In hyperthyroidism, hyper refers to having too much, and thyroid refers to thyroid hormone. So Graves' disease refers to a condition where there's excess thyroid hormones. Now, normally the hypothalamus, which is located at the base of the brain, detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin or just TSH. TSH stimulates the thyroid gland, which is a gland in the neck that looks like two thumbs hooked together in the shape of a V. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, which is a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, at which point it can exert its effect. T3 speeds up the basal metabolic rate. So as an example, they might produce more proteins and burn up more energy in the form of sugars and fats. It's like the cells are in kind of a frenzy. T3 also increases cardiac output, stimulates bone resorption, which thins out the bones, and activates the sympathetic nervous system, which is the part of the nervous system that's responsible for our fight or flight response. That being said, thyroid hormone is important, and the occasional increase is kind of like getting a boost to fight off a hungry predator or to stay warm during a snowstorm. Now, in Graves' disease, the trigger is unclear, but for some reason, the B cells start to produce a few different types of antibodies against thyroid proteins. The most common antibody is the thyroid-stimulating immunoglobulin, which binds to the TSH receptor on thyroid cells, thereby imitating TSH, and stimulating the thyroid cells to release more T3 and T4. But the effects of thyroid-stimulating immunoglobulins can also directly affect certain tissues. First, there's thyroid hypertrophy, meaning growth in the interstitium of the tissue, and there's hyperplasia, meaning an increased number of follicular cells, both of which causes the thyroid to enlarge. The follicular cells also change shape, becoming taller than in a healthy thyroid as they crowd together. Second, in response to the thyroid-stimulating antibody, the follicular cells also start to express molecules on their surface that attract nearby T cells. The circulating T cells bind to the follicular cells and infiltrate into the interstitium of the thyroid tissue, which is the space between follicular cells. Third, it turns out that the fibroblasts in the tissue around the eyes and in the skin also get stimulated by thyroid-stimulating antibodies, and they start to multiply and make extracellular matrix proteins called glycosaminoglycans, which build up in the tissues over time. The symptoms of Graves' disease can be summed up with the triad of hyperthyroidism, ophthalmopathy, and dermopathy. Thyroid-stimulating immunoglobulins target and activate the TSH receptor, causing goiter, which is a term used to describe an enlarged thyroid because of the hypertrophy and hyperplasia of the gland, weight loss despite an increase in appetite because of the higher basal metabolic rate, heat intolerance because the body is producing more heat, and rapid heart rate, sweating, hyperactivity, anxiety, and insomnia because of the effect of thyroid hormones on the sympathetic nervous system. The buildup of glycosaminoglycans causes local inflammation and swelling around the eyes, called Graves' ophthalmopathy. The ophthalmopathy causes exophthalmos, or outward bulging of the eyeball, as well as weakens the muscles that control eye and upper eyelid movements, and can damage the cornea over time because exophthalmos can dry out the eyes and increase the risk of corneal ulcers. Pretibial myxedema, caused by glycosaminoglycan buildup, can lead to non-pitting edema or swelling, and skin thickening, usually over the shins. Thyroid storm, which is a life-threatening complication of hyperthyroidism where the body goes into a state of severe hypermetabolism, can develop when someone with hyperthyroidism stops their treatment, develops an infection, or has surgery. All of the normal symptoms of hyperthyroidism become exaggerated. For example, heat intolerance turns to high fever and rapid heart rate turns to cardiac arrhythmia. Individuals with Graves' disease are also more likely to develop other autoimmune conditions, like rheumatoid arthritis or diabetes mellitus type 1. Diagnosing Graves' disease involves measuring blood levels of TSH, as well as T3 and T4. Measuring thyroid-stimulating antibodies will confirm Graves' disease as the cause of the hyperthyroidism. Radioiodine scans and measurements of iodine uptake can also support the diagnosis. Graves' disease is mostly treated using medication, like beta blockers to treat the immediate symptoms of hyperthyroidism, and antithyroid drugs to block thyroid hormone production and release. Radioiodine therapy can be used to partially or completely destroy thyroid function, followed by replacement hormone therapy. In cases where a large goiter is compressing surrounding tissue, surgery is used to remove the thyroid. Graves' ophthalmopathy usually needs separate treatment, which can include steroids, radiation therapy, and surgery. Alright, as a quick recap, Graves' disease is an autoimmune disease where the body produces autoantibodies, including thyroid-stimulating immunoglobulins, which causes excess production of thyroid hormones. It affects follicular cells in the thyroid and in fibroblasts around the eyes and in the skin, and the result is hyperthyroidism, ophthalmopathy, and dermopathy.
Thyroid eye disease is a rare disease in which progressive inflammation damages muscle, fat, and connective tissues around the eyes. The disease has an active phase, which can last from 6 months to 2 years, where inflammation, swelling, and damage occur. The inactive phase occurs when disease progression stops, but the tissue damage and symptoms remain. Signs and symptoms can vary between individuals, but commonly, the white parts of the eyes are inflamed. A particularly noticeable change is the eyes appear to be bulging out of the eye socket, called exophthalmos, or proptosis, which makes a person appear as if they are always staring. Additionally, the eyes can feel irritated, uncomfortable, and have a gritty feeling. They may also be constantly watery, or be dry. The eyelids can become inflamed and retracted, so they won't close completely, and blinking or trying to close the eyes can be painful. Vision changes may also occur, including blurry vision, double vision, or an intolerance to bright lights. In severe cases, vision may be threatened from increased pressure on the main nerve of the eye that carries visual information to the brain, or from dryness leading to erosion of the cornea, which is the outer part of the eye. Thyroid eye disease usually occurs during middle age. While it's more frequent among females, males tend to have more severe cases. Environmental factors such as smoking may contribute, but there's also a variety of genetic factors. Individuals may have an elevated risk if they also have immune diseases like type 1 diabetes or rheumatoid arthritis. Because thyroid eye disease occurs so often with Graves' disease, it's also called Graves' orbitopathy, Graves' ophthalmopathy, and thyroid-associated ophthalmopathy. The exact underlying process by which thyroid eye disease occurs is not fully understood. But like Graves' disease, it's an autoimmune disorder. Normally, the immune system protects the body by identifying and destroying foreign invaders, like bacteria, viruses, or toxins. The adaptive immune system is in charge of creating specialized proteins called antibodies that attack and destroy specific invaders. But in autoimmune disorders, the adaptive immune system mistakenly attacks the body's own healthy tissues. In thyroid eye disease, the immune system makes abnormal antibodies, called thyroid-stimulating immunoglobulin, and they circulate around the body and attach to specific receptors on the thyroid and other tissues, like those found in the eyes. Once they attach, the antibodies cause the immune system to attack the eyes, leading to inflammation and damage to the eye's muscle, fat, and connective tissues. Individuals who develop thyroid eye disease also have an increased expression of insulin-like growth factor 1 receptor, abbreviated IGF-1R, on the tissue around the eye. Researchers believe this receptor plays a significant role in the development of the disorder. Antibodies against these receptors are produced in people with thyroid eye disease, and once bound to the IGF-1R, they can increase collagen production. Collagen builds up in the tissue around the eyes, causing excessive fibrosis or scar tissue formation. This pushes on nerves, blood vessels, and the eye itself. Diagnosis is based on patient history and the signs and symptoms of the disease, like changes in the appearance of the eyes and vision changes. Some clinical tests can assess these changes, like measuring the degree of proptosis with a specialized device called an exophthalmometer and having an eye exam. Additionally, medical imaging can also be helpful. Treatment includes teprotumumab, which blocks IGF-1R activation. It's approved by the FDA for the treatment of thyroid eye disease. Management of underlying diseases that might be affecting thyroid activity, like corticosteroids or prednisone to control inflammation, may be helpful. Radiation therapy can be an option, and so can surgery to remove some of the bone around the eye to relieve pressure or reposition muscles or eyelids. Supportive treatments include using artificial tears to prevent dry eyes and eye patches or prisms to reduce double vision. As a quick recap, thyroid eye disease is a rare autoimmune disease in which the immune system produces abnormal antibodies that cause the immune system to attack the tissues around the eyes, causing inflammation and damage. They also increase collagen synthesis and fibrosis around the eyes. Signs and symptoms include changes in the eyes, eyelids, and vision. Diagnosis is made with clinical tests and medical imaging. Treatments include teprotumumab, corticosteroids, orbital decompression surgery, and supportive care.
Thyrotoxic crisis, more commonly called thyroid storm, is a severe, acute complication of hyperthyroidism. In hyperthyroidism, there's an excess of thyroid hormone, and in thyroid storm, the symptoms and physiologic effects of having excessive thyroid hormones are suddenly magnified. Normally, the hypothalamus, which is located at the base of the brain, detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin, or simply TSH. TSH stimulates the thyroid gland, which is a gland located in the neck that looks like two thumbs hooked together in the shape of a V. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to the circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, where it can exert its effect. T3 speeds up the cell's basal metabolic rate. So as an example, the cell might produce more proteins and burn up more energy in the form of sugars and fats. It's as if the cells are in a bit of a frenzy. T3 increases cardiac output, stimulates bone reabsorption, thinning out the bones, and then activates the sympathetic nervous system, the part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase can be really useful when you need a boost to get through the final rounds of a sporting competition, or when you're trying to stay warm during a snowstorm. Now, hyperthyroidism can happen a few different ways. All of them result in too much thyroid hormone in a hypermetabolic state, where cellular reactions are happening faster than normal. The most common primary cause is Graves' disease, an autoimmune disorder where B cells produce antibodies against several thyroid proteins. These autoantibodies include thyroid-stimulating immunoglobulins, which bind to the TSH receptor on the follicular cells and imitate TSH. Another primary cause is toxic nodular goiter, where one or more follicles starts generating lots of thyroid hormone. In some cases, it's because of a mutated TSH receptor that inappropriately keeps these follicular cells active. Regardless of the cause of hyperthyroidism, occasionally a person can develop thyroid storm, which is when the effect of having excess thyroid hormones is suddenly magnified. The exact reason that this happens is unclear, but there are some proposed mechanisms. The first is that there may be more unbound thyroid hormone in the blood, which is the active form of the hormone. The second is that the level of unbound thyroid hormone may be unchanged, but the tissues might become more sensitive to thyroid hormone. Third, the body might become more sensitive to catecholamines like epinephrine or dopamine, which are part of the sympathetic nervous system. Triggers for thyroid storm include stressors like surgery, trauma, infection, or childbirth. Other triggers are abruptly stopping treatment for hyperthyroidism or taking too much thyroid hormones, which is relevant for individuals that have hypothyroidism. The end result is the same, a state of severe hypermetabolism, so all the effects of the excess thyroid hormones on the body are magnified. The symptoms of thyroid storm are mostly an exaggerated version of the symptoms of hyperthyroidism, which include weight loss despite an increase in appetite because of the higher basal metabolic rate, heat intolerance because the body is producing more heat, and rapid heart rate, sweating, hyperactivity, anxiety, and insomnia because of the effects of thyroid hormones on the sympathetic nervous system. In thyroid storm, heat intolerance turns to fever. Hyperactivity and anxiety turn into agitation, confusion, and can go as far as seizures and coma. Cardiovascular symptoms like tachycardia can turn into cardiac arrhythmias and high output cardiac failure. Thyroid storm can be extremely severe and can cause death if it's not quickly recognized and managed. The diagnosis of thyroid storm is usually based on the severity of symptoms and can be confirmed by tests like an ECG to detect a cardiac arrhythmia. Typically, there isn't much of a difference in thyroid hormone levels between hyperthyroidism and thyroid storm. The biggest difference is how the hormone levels affect the various body systems. Treatment for thyroid storm requires intensive supportive care, with various medications like beta blockers to treat symptoms, thionamides to block thyroid hormone production, as well as iodine preparations, glucocorticoids, and bile acid sequestrants. All of these medications are aimed at reducing the amount of thyroid hormone and its effects on the body. If this approach doesn't work, plasmapheresis can be tried. That's where blood plasma is removed, thyroid hormone can also be removed, and the remaining plasma is returned to the person. Alright, as a quick recap, thyroid storm is an acute, life-threatening complication of hyperthyroidism, where the body becomes very sensitive to the effects of excess thyroid hormone. It can cause symptoms like high fever and severe tachycardia, and because of its high mortality rate, medications like beta blockers and thionamides have to be given rapidly.
In toxic multinodular goiter, also called plumber's disease, toxic refers to something harmful, nodular refers to little lumps or nodules of tissue, and goiter refers to a large thyroid gland. So toxic multinodular goiter is a condition where the thyroid gland enlarges and is filled with lots of little nodules of tissue, each of which produces so much thyroid hormone that it becomes harmful to the body. Now, normally the hypothalamus, which is located at the base of the brain, detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin, or just TSH. TSH stimulates the thyroid gland, which is a gland in the neck that looks like two thumbs hooked together in the shape of a V. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, which is a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, at which point it can exert its effect. T3 speeds up the basal metabolic rate, so as an example, they might produce more proteins and burn up more energy in the form of sugars and fats. It's like the cells are in kind of a frenzy. T3 also increases cardiac output, stimulates bone resorption, which thins out the bones, and activates the sympathetic nervous system, which is the part of the nervous system that's responsible for our fight or flight response. That being said, thyroid hormone is important, and the occasional increase is kind of like getting a boost to fight off a hungry predator or to stay warm during a snowstorm. Toxic multinodular goiter usually starts with a chronic lack of dietary iodine, and follicular cells need iodine to make T3 and T4. With less iodine around, each follicular cell makes less thyroid hormone, and as a whole, the level of thyroid hormone goes down. In response to low levels of thyroid hormones, the anterior pituitary releases TSH. The high levels of TSH cause thyroid hypertrophy, which is the buildup in thyroid tissue, and hyperplasia, which increases the number of follicular cells. Some parts of the thyroid gland are more responsive to TSH than others, so the growth ends up being uneven throughout the thyroid. Those responsive follicular cells start to grow quickly and develop into a nodule, and the rest of the gland ends up looking basically the same. Typically, multinodular goiter starts with a single nodule, and then over the years, multiple nodules start to appear. This strategy works for a while, and the thyroid is considered a non-toxic multinodular goiter. In other words, having more follicular cells makes up for the fact that each follicular cell makes less thyroid hormone. So the thyroid enters a balanced or euthyroid state. At this point, the TSH levels go down even though there's an iodine deficiency. But if that iodine deficiency worsens, there's another round of increased TSH, which stimulates more thyroid growth. Over time, the thyroid gland goes through a ton of cycles of periods of growth and periods of balance. Now, a non-toxic multinodular goiter becomes toxic when a genetic mutation happens in one of the dividing follicular cells, in particular when the mutation affects the TSH receptor. If the mutation causes the TSH receptor to be constantly on, then the affected cell might constantly remain stimulated to divide and produce thyroid hormone. At this point, it develops into a toxic nodular goiter. Even when thyroid hormone levels rise and TSH production shut down, these independent nodules use any available iodine to make thyroid hormone, well beyond what the body wants or needs. The result is that cells across the body are in a state of hypermetabolism, where cellular reactions are constantly happening at a faster pace than normal. Symptoms of toxic multinodular goiter are related to the enlargement of the thyroid gland and to hyperthyroidism. The enlarged thyroid gland can put pressure on other structures in the neck, obstructing the airway and making swallowing difficult. It can also compress nerves like the superior or recurrent laryngeal nerves, which will make the voice sound hoarse. It can cause superior vena cava syndrome by limiting blood flow in the superior vena cava, which results in facial and arm swelling because blood gets backed up in the veins of the head and upper body. Hyperthyroidism causes weight loss despite an increase in appetite because of the higher basal metabolic rate, as well as heat intolerance because the body's producing more heat, and rapid heart rate, sweating, hyperactivity, anxiety, and insomnia because of the effect of thyroid hormones on the sympathetic nervous system. Sympathetic overstimulation of muscles that control eye movements also makes the eyes appear more open than normal, so you see more of the white of the eyes. Thyroid storm, which is a life-threatening complication of hyperthyroidism where the body goes into a state of severe hypermetabolism, can develop when someone with hyperthyroidism stops their treatment, develops an infection, or has surgery. All of the normal symptoms of hyperthyroidism become exaggerated. For example, heat intolerance turns to high fever and rapid heart rate turns to cardiac arrhythmia. Diagnosing toxic multinodular goiter involves confirming hyperthyroidism by measuring blood levels of TSH, T3, and T4, and confirming the presence of multinodular goiter through ultrasonography. A radioiodine uptake test can also help identify independent nodules. The treatment for toxic multinodular goiter is usually done with beta blockers, and surgery can be used to remove part or all of the thyroid gland. Another option, radioiodine therapy, involves taking oral doses of radioactive iodine, which is absorbed by active follicular cells and over time damages them. This destroys hyperfunctioning nodules within the thyroid gland because radioiodine gets preferentially picked up by those nodules, leaving the rest of the gland intact. The long-term use of thioamides, which are antithyroid drugs which block thyroid hormone production and secretion, is typically only used when radioiodine therapy and surgery aren't appropriate options. Alright, as a quick recap, toxic multinodular goiter is a condition where the thyroid gland develops independently functioning nodules, which results in hyperthyroidism. It develops after prolonged iodine deficiency, which causes hypertrophy and hyperplasia of the thyroid gland. Continued follicular cell division can lead to a genetic mutation of the TSH receptor, which turns a non-toxic multinodular goiter into a toxic multinodular goiter. Symptoms include an enlarged thyroid as well as the typical symptoms of hyperthyroidism, like weight loss, a rapid heart rate, and hyperactivity.
On the endocrinology ward, 2 individuals came in. The first one is 23-year-old Hannah, who complains of lethargy, fatigue, reduced appetite, muscle weakness, and constipation. She also says that lately she gained a bit of weight and has a low libido. On clinical examination, she has periorbital edema, dry, cool skin, her nails are brittle, and her reflexes are slow. She also has a moderately enlarged, painless goiter. The other person is 33-year-old Quentin, who also presents with lethargy, fatigue, reduced appetite, muscle weakness, constipation, and he's also complaining about feeling cold all the time. He said that he recently had the flu, but no other illnesses. On clinical examination, there's also periorbital edema, dry, cool skin, brittle nails, and hair, but a very painful goiter. TSH, free T3, and T4 are taken, along with antithyroid peroxidase and antithyroglobulin antibodies. Both Hannah and Quentin have high levels of TSH and low T3 and T4 levels, but Hannah has positive antithyroid peroxidase and antithyroglobulin antibodies. Both individuals seem to have hypothyroidism. First, a bit of physiology. Normally, the hypothalamus detects low serum levels of thyroid hormones and releases thyrotropin-releasing hormone, or TRH, into the hypophyseal portal system. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin or simply TSH. TSH stimulates the thyroid gland. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, a protein found in follicles, into 2 iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and can act upon nearly every type of cell in the body. Once inside the cell, T4 is usually converted into T3, and it can exert its effect. T3 speeds up the cell's basal metabolic rate. It increases cardiac output, stimulates bone resorption, basically thinning out the bones, and activates the sympathetic nervous system. Thyroid hormones are also involved in a number of other things, like controlling sebaceous and sweat gland secretions, hair follicle growth, and regulating proteins and mucopolysaccharide synthesis by skin fibroblasts. Now, hypothyroidism can happen a few different ways, and all of them result in a decrease in thyroid hormones and a decreased basal metabolic rate, where cellular reactions are happening slower than normal. There are 3 types of hypothyroidism. In primary hypothyroidism, the thyroid gland is the problem because it isn't making enough thyroid hormones. Not only is there a lack of T3 and T4, which causes a slowing down of metabolic processes, but there are also increased levels of TSH from the pituitary to try to stimulate the gland. A secondary effect of the high levels of TSH is that it stimulates fibroblasts in the skin and soft tissues. The stimulated fibroblasts start depositing glycosaminoglycans in the interstitium. Secondary hypothyroidism is caused by damage to the pituitary, and tertiary hypothyroidism is caused by damage to the hypothalamus. These are sometimes called central hypothyroidism. A high-yield fact for your exam is that they can lead to a decrease in TSH release, which decreases the activity of the thyroid. Regardless of the cause, symptoms of hypothyroidism are the same, and in order to remember them better, keep in mind that hypothyroidism slows down almost everything. It can take years to manifest and affect multiple systems. Metabolic findings include modest weight gain and cold intolerance due to the low basal metabolic rate. Skin and hair findings include cool skin due to vasoconstriction and dry skin due to reduced secretion of the sweat glands and sebaceous glands. The hair is coarse and brittle, and there can be diffuse alopecia. Also, the nails are brittle. Hypothyroidism leads to an increase in glycosaminoglycans in the interstitium, which can elevate the osmotic pressure, leading to water retention and eventually non-pitting edema. As a result, the individual has a puffy appearance, called myxedema. Ocular findings include periorbital edema. Gastrointestinal findings include constipation due to low GI motility, and there's also reduced appetite. Musculoskeletal findings include hypothyroid myopathy, which presents with muscle weakness, especially proximal weakness. Sometimes there can also be muscle damage, and in this case, CK levels are increased. It's not exactly understood why this happens, but it's known that thyroid hormones have a great influence on cell metabolism, and this includes muscle cell metabolism. Sometimes carpal tunnel syndrome can appear, and it's thought that this happens due to the accumulation of glycosaminoglycans. There can also be myoedema, which is a bump caused by local muscle contraction when triggered by light percussion with an object. The prolonged muscle contraction is a result of the alterations in muscle fibers caused by hypothyroidism. Reproductive findings include menorrhagia, oligomenorrhea, and low libido in females, and even infertility. These changes can occur due to deficient LH secretion. Neuropsychiatric findings include hypoactivity, lethargy, fatigue, weakness, depressed mood, and slower reflexes. Finally, cardiovascular findings include bradycardia, low cardiac output, and dyspnea after exercising. Diagnosing hypothyroidism is done by measuring blood levels of TSH, T3, and T4. In all cases, thyroid hormones will be low, but TSH levels vary. If it's due to a primary cause, TSH will be high, and if it's due to a secondary cause, TSH will either be low or normal. There can also be hypercholesterolemia due to low LDL receptor expression. Okay, now let's talk about the causes of hypothyroidism, starting with the causes of primary hypothyroidism. First, there's Hashimoto's thyroiditis, which is the most common cause of primary hypothyroidism in countries that fortify foods with iodine. This is an autoimmune disorder where T cells and autoantibodies like antithyroid peroxidase and thyroglobulin antibodies infiltrate the thyroid. Remember these antibodies because this is very high yield. Now, there is a gene complex involved in the regulation of the immune response, and this is called the human leukocyte antigen system, or HLA system. Interestingly, individuals with Hashimoto's thyroiditis often have specific HLA genes in common with each other, and one that is associated with Hashimoto's thyroiditis is HLA-DR3, which is high yield for your tests. Damage to some parts of the thyroid and the subsequent increase in TSH leads to thyroid hypertrophy and hyperplasia. In other words, the thyroid responds to autoimmune damage by increasing the size and number of healthy follicular cells, both of which causes the thyroid to enlarge. Unfortunately, this compensation is short-lived, and eventually the autoantibodies cause so much follicular cell damage that they destroy thyroid function altogether. In the beginning, as the follicles rupture, they release a pretty high amount of thyroid hormones, resulting in an initial phase of hyperthyroidism. On histology, with Hashimoto's thyroiditis, there can be Hirtla cells, which are also called oncocytes. These cells arise from the follicular epithelium, have an eosinophilic cytoplasm, and a vesicular nucleus with a large nucleolus. There can also be lymphoid aggregates with germinal centers. On clinical examination, there can be a goiter, which is an enlarged thyroid gland that doesn't cause pain. In individuals with Hashimoto's thyroiditis, there's a higher risk for developing lymphoma. Moving on to subacute granulomatous thyroiditis, also called de Quervain thyroiditis, which is a self-limited condition that often follows a flu-like illness, such as a viral infection. What you must know for your tests is that this is an inflammatory condition where the follicular cells are damaged by inflammation. Its evolution typically has 3 phases. First, there can be hyperthyroidism due to the extra thyroid hormones released by the damaged follicles, followed by hypothyroidism, and then there's the return to normal thyroid function. On histology, in the early phases, there are neutrophils and destruction of follicles with colloid depletion. Later on, granulomas that surround the follicles can be seen. On clinical examination, there's jaw pain and the thyroid is very tender. Labs will show high ESR. Next, there's renal thyroiditis, which is a chronic inflammatory condition of the thyroid where the thyroid tissue is replaced by fibrous tissue with inflammatory infiltrate. Although the etiology of renal thyroiditis is unknown, it's thought that it's related to systemic conditions that affect immunoglobulin G4, such as autoimmune pancreatitis, retroperitoneal fibrosis, and non-infectious aortitis. Usually, 1/3 of individuals are hypothyroid. Fibrosis sometimes can extend to local structures, like the trachea and esophagus, and due to extension, it can sometimes be mistaken for anaplastic carcinoma. On the clinical examination, there's a fixed, hard, painless goiter. Next, there's postpartum thyroiditis, which is a self-limited thyroiditis that can happen up to 1 year after delivery. The exact cause isn't known, but it's considered to be autoimmune. It can have different clinical presentations, such as transient hyperthyroidism, hypothyroidism, or hyperthyroidism followed by hypothyroidism. On histology, there's a lymphocytic infiltrate with occasional germinal center formation. Next, we have congenital hypothyroidism, also called cretinism, which affects newborns. It can be caused by antibody-mediated maternal hypothyroidism, which is when the maternal antibodies can destroy the newborn's thyroid. Other causes include thyroid agenesis, when the thyroid gland doesn't form at all, or thyroid dysgenesis, which is when the thyroid gland is abnormally formed, and this is also the most common cause of cretinism in the US. Finally, it can be caused by iodine deficiency, or by dyshormonogenic goiter, which is when there's a lack of enzymes for the synthesis of thyroid hormones. Remember that some of the mother's thyroid hormones are passed on to the baby, so symptoms will only manifest after these hormones are gone. These include the 6 Ps: pot-bellied, pale, puffy-faced, protruding umbilicus, protuberant tongue, and poor brain development. Finally, hypothyroidism can be caused by iodine deficiency, and this is common in low-income countries that don't fortify food with iodine. Another cause of primary hypothyroidism is the Wolff-Chaikoff effect. This is an autoregulatory phenomenon that happens when there's too much iodine. With too much iodine, the thyroid responds by inhibiting the synthesis of thyroid hormones in order to avoid producing too many hormones. This doesn't last forever, though. Eventually, the thyroid will escape this effect and resume thyroid hormone production. Other causes include medications that decrease thyroid hormone synthesis, like amiodarone, lithium, and sulfonamides. Central hypothyroidism is far less common. Secondary is usually due to an anterior pituitary tumor, or an infarction that damages the gland and prevents TSH production. Tertiary hypothyroidism occurs when there's damage to the hypothalamus, and this can be due to trauma or a lesion that compresses the region, leading to decreased thyrotropin-releasing hormone production. Treatment for all types of hypothyroidism is a thyroid hormone replacement therapy, primarily using levothyroxine, a synthetic T4. Alright, as a quick recap, hypothyroidism can be primary when the thyroid gland is the problem, secondary where the pituitary gland is affected, or tertiary where the hypothalamus is damaged. Hypothyroidism can affect multiple systems, causing weight gain, cold intolerance, skin and hair findings, myxedema, periorbital edema, constipation, and myoedema. Reproductive findings are more common in females and include menorrhagia, oligomenorrhea, low libido, and infertility. Neuropsychiatric findings include hypoactivity, lethargy, fatigue, weakness, depressed mood, and slower reflexes. Finally, cardiovascular findings include bradycardia, low cardiac output, and dyspnea after exercising. Diagnosing hypothyroidism is done by measuring blood levels of TSH, T3, and T4. In all cases, thyroid hormones will be low, but TSH level is elevated in primary hypothyroidism. Primary causes of hypothyroidism include Hashimoto's thyroiditis, subacute granulomatous thyroiditis, also called de Quervain, renal thyroiditis, postpartum thyroiditis, and congenital hypothyroidism, also called cretinism, which affects the newborn. Other causes of primary hypothyroidism include iodine deficiency, Wolff-Chaikoff effect, and medications like lithium. Okay, back to our cases. Hannah came in with the classic symptoms and signs of hypothyroidism, like lethargy, fatigue, reduced appetite, muscle weakness, constipation, along with weight gain, low libido, periorbital edema, dry, cool skin, brittle nails, and slow reflexes. Lab tests confirmed primary hypothyroidism because they showed high levels of TSH along with low levels of T3 and T4. She also had a moderately enlarged, painless goiter, and this, along with the positive antithyroid peroxidase and antithyroglobulin antibodies, makes the diagnosis of Hashimoto's thyroiditis. Quentin also presents with symptoms of hypothyroidism, which the labs confirm is primary in nature due to the elevated TSH. However, his goiter is very painful, and, along with his history of a viral infection, the likely diagnosis is subacute granulomatous thyroiditis.
In hypothyroidism, hypo refers to having too little, and thyroid refers to thyroid hormone. So hypothyroidism refers to a condition where there's a lack of thyroid hormones. Now, normally the hypothalamus, which is located at the base of the brain, detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin, or just TSH. TSH stimulates the thyroid gland, which is a gland in the neck that looks like two thumbs hooked together in the shape of a V. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, which is a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, at which point it can exert its effect. T3 speeds up the basal metabolic rate. So as an example, they might produce more proteins and burn up more energy in the form of sugars and fats. It's like the cells are in kind of a frenzy. T3 also increases cardiac output, stimulates bone resorption, which thins out the bones, and activates the sympathetic nervous system, which is the part of the nervous system that's responsible for our fight or flight response. That being said, thyroid hormone is important, and the occasional increase is kind of like getting a boost to fight off a hungry predator or to stay warm during a snowstorm. Now, hypothyroidism can happen a few different ways, and all of them result in a lack of thyroid hormones and a decreased basal metabolic rate, where cellular reactions are happening slower than normal. There are two types of hypothyroidism, primary and secondary. In primary hypothyroidism, the thyroid gland's the problem, because it isn't making enough thyroid hormones. Not only is there a lack of T3 and T4, which causes a slowing down of metabolic processes, but there are increased levels of TSH from the pituitary to try to stimulate the gland. A secondary effect of the high levels of TSH is that it stimulates fibroblasts in the skin and soft tissue. The stimulated fibroblasts start depositing glycosaminoglycans, which are extracellular matrix proteins, into the interstitium, which is the space between cells. Iodine deficiency is the most common cause of primary hypothyroidism in low-income countries that don't fortify their food with iodine. This causes primary hypothyroidism because the follicular cells don't have the iodine they need to produce T3 and T4. In countries that do fortify foods with iodine, the most common cause of primary hypothyroidism is Hashimoto thyroiditis, which is an autoimmune disorder where T cells and autoantibodies like anti-thyroid peroxidase and anti-thyroglobulin infiltrate the thyroid. Damage to some parts of the thyroid and the subsequent increase in TSH leads to thyroid hypertrophy and hyperplasia. In other words, the thyroid responds to autoimmune damage by increasing the size and number of healthy follicular cells, both of which causes the thyroid to enlarge. Unfortunately, this compensation is short-lived, and eventually the autoantibodies cause so much follicular cell damage that they destroy thyroid function altogether. Primary hypothyroidism can also happen after treatment for hyperthyroidism, either because the surgery removes part or all of the thyroid gland, or because radioiodine therapy damages too many follicular cells. Another type of primary hypothyroidism is when it affects a newborn, in which case it's called congenital hypothyroidism. Most of the time this is sporadic, meaning it happens at random, but it can also be caused by an inherited genetic mutation. Ultimately, the newborn's thyroid gland doesn't make enough thyroid hormones, either because it doesn't develop normally, in which case the gland could be absent, underdeveloped, or develop in the wrong place in the body, or because there's a defect within a normal-looking thyroid gland that affects its ability to make thyroid hormones. Now, in secondary hypothyroidism, also called central hypothyroidism, the issue is that the body doesn't produce enough TSH. This typically happens because there's a tumor in the anterior pituitary which compresses the gland and prevents TSH production, or because there's damage to the hypothalamus from tumors or trauma, which decreases thyrotropin-releasing hormone production. The symptoms of hypothyroidism, which can take years before they're even recognized, include weight gain despite a loss in appetite because of the lower basal metabolic rate, cold sensitivity because the body's producing less heat, as well as slower heart rate, mental slowness, lethargy, and constipation because of the decreased effect of thyroid hormones on the sympathetic nervous system. Accumulation of glycosaminoglycans also causes myxedema, or swelling in the skin and soft tissues like the tongue. If the hypothyroidism is caused by Hashimoto thyroiditis, there can be a goiter, which is an enlarged thyroid gland, because of the hypertrophy and hyperplasia of the gland. Babies with congenital hypothyroidism will have symptoms related to the decreased metabolic rate like excessive sleeping. But if the condition isn't detected quickly enough, they're at risk for irreversible intellectual disabilities, as well as delayed physical growth and shortened height because of the role of thyroid hormones in brain and sympathetic nervous system development. There's also a severe, life-threatening form of hypothyroidism called myxedema coma, which affects people with poorly managed hypothyroidism who undergo a stressful situation, like a serious infection or surgery. For example, mental slowness turns into altered consciousness and confusion, and decreased body temperature turns to hypothermia. Diagnosing hypothyroidism is done by measuring blood levels of TSH, T3, and T4. In all cases, thyroid hormones will be low, but TSH levels vary. If it's due to a primary cause, TSH will be high, and if it's due to a secondary cause, TSH will either be low or normal. Because congenital hypothyroidism can be hard to detect in newborns, a lot of countries screen all newborns for congenital hypothyroidism within the first few weeks of life. Treatment for all types of hypothyroidism is thyroid hormone replacement therapy, primarily using synthetic T4. Alright, as a quick recap, hypothyroidism refers to a condition where there's a lack of thyroid hormones. In primary hypothyroidism, the thyroid gland isn't working properly, as a result of an autoimmune disease like Hashimoto thyroiditis, hyperthyroidism treatment, or a congenital defect. In secondary hypothyroidism, either the anterior pituitary gland or the hypothalamus is the problem, usually because of a tumor or damage from surgery. In all cases, the lack of thyroid hormones can cause a decreased metabolic state, with symptoms like weight gain, mental slowness, swelling of the skin and soft tissues, and a slower heart rate. The term euthyroid 6 syndrome, also known as non-thyroidal illness syndrome, can be broken down. Eu refers to good, and thyroid refers to the thyroid gland, which produces thyroid hormones. So euthyroid 6 syndrome is a state where the thyroid gland is functioning normally, but the thyroid hormones are at abnormal levels. Now, normally, the hypothalamus, which is at the base of the brain, secretes thyrotropin-releasing hormone, or TRH, into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary gland. The anterior pituitary then releases thyroid-stimulating hormone, aka thyrotropin, or just TSH. TSH stimulates the thyroid gland, which is a gland found in the neck that looks like two thumbs hooked together in the shape of a V. If we zoom into the thyroid gland, we'll find thousands of follicles, which have a sticky substance called colloid, which sits within follicular cells. Follicular cells convert the protein thyroglobulin into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and the majority is bound to circulating plasma proteins, with only a small amount of T3 and T4 traveling unbound in the blood. Ultimately, these two hormones get picked up by nearly every cell in the body, and once inside the cell, T4 is mostly converted to T3, at which point it can exert its effect. T3 speeds up the basal metabolic rate. So as an example, they might produce more proteins and burn up more energy in the form of sugars and fats. It's like the cells are kind of in a frenzy. T3 increases cardiac output, stimulates bone resorption, which thins out the bones, and activates the sympathetic nervous system, which is a part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase is like getting a boost to fight off a hungry predator, or to stay warm during a snowstorm, or both. Thyroid hormones are also involved in a number of other things, like controlling sebaceous and sweat gland secretion, hair follicle growth, and regulating proteins and mucopolysaccharide synthesis by skin fibroblasts. In euthyroid 6 syndrome, even though the thyroid gland's functioning normally, there's still a deficiency of thyroid hormones in the bloodstream, particularly T3. The cause of this isn't well understood, but typically it happens in catabolic states, where the body's breaking down proteins, like starvation or when there's a serious illness. When there's not enough food available, our body adapts by conserving energy, and one way to do that is to produce fewer structural proteins and enzymes. One enzyme that's found in various body tissues, including the thyroid, liver, and kidneys, is deiodinase, which converts T4 to the more potent T3. In catabolic states, there's less deiodinase, and that leads to a lower level of T3 in the blood. Also, during catabolic states, especially during a serious illness, immune cells produce cytokines like interleukin 6, tumor necrosis factor alpha, and interferon beta. These cytokines act directly on the hypothalamus and pituitary gland to decrease the production of TSH and thyroid hormones, respectively, which also leads to decreased T4 and T3 levels. Since the thyroid tissue is healthy and not directly affected in euthyroid 6 syndrome, once a person starts eating again or once they recover from an illness, thyroid hormone levels return to normal. In euthyroid 6 syndrome, there's usually no symptoms of hypothyroidism, because it's typically a temporary state. In diagnosing euthyroid 6 syndrome, there's normal to low levels of T4, low levels of T3, and normal to low levels of TSH, whereas in hypothyroidism, TSH levels are usually elevated. The treatment of euthyroid 6 syndrome is based on treating the underlying cause. Once the cause has been treated, thyroid hormone levels return to normal. Alright, as a quick recap, euthyroid 6 syndrome is where the thyroid tissue is not diseased, but the thyroid hormones are at unusually low levels. This is usually caused by starvation or a serious illness, and can be distinguished from hypothyroidism by the normal or low levels of TSH. Hashimoto's thyroiditis, named after the Japanese physician Hikaru Hashimoto who first described it, belongs to a group of disorders where there's some form of inflammation of the thyroid gland. It's basically an autoimmune destruction of the thyroid gland, which typically progresses gradually to hypothyroidism, or a state of low thyroid hormones. In fact, Hashimoto's thyroiditis is the most common cause of hypothyroidism in areas of the world where dietary iodine, which is the basic structural element of thyroid hormones, is sufficient. Normally, the hypothalamus, which is located at the base of the brain, secretes thyrotropin-releasing hormone, or TRH, into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases a hormone of its own, called thyroid-stimulating hormone, thyrotropin, or just TSH. TSH stimulates the thyroid gland, which is a gland located in the neck that looks like two thumbs hooked together in the shape of a V. If we zoom into the thyroid gland, we'll find thousands of follicles, which are small, hollow spheres whose walls are lined with follicular cells, and are separated by a small amount of connective tissue. Follicular cells convert thyroglobulin, which is a protein found in follicles, into iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, at which point it can exert its effect. T3 speeds up the basal metabolic rate. So as an example, they might produce more proteins and burn up more energy in the form of sugars and fats. It's kind of like the cells are in a bit of a frenzy. T3 increases cardiac output, stimulates bone resorption, which thins out the bones, and activates the sympathetic nervous system, which is the part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase is like getting a boost to fight off a zombie, or to stay warm during a snowstorm. Thyroid hormones are also involved in a number of other things, like controlling sebaceous and sweat gland secretion, hair follicle growth, and regulating proteins and mucopolysaccharide synthesis by skin fibroblasts. For all of this to work right, the levels of thyroid hormones have to stay within a normal range. To do that, the body uses negative feedback, which means that low levels of thyroid hormones tell the hypothalamus and pituitary gland to increase their secretion of TRH and TSH, respectively. More TRH increases TSH production in the pituitary, and the thyroid gland gets more stimulation to make thyroid hormones. And eventually, T3 and T4 levels go back up to the normal range again. When there's increased TRH, though, the pituitary gland also gets stimulated to produce more prolactin, whose job is to stimulate breast milk production and inhibit ovulation, which is when an egg cell is released from the ovary, as well as inhibit spermatogenesis, which is the development of sperm cells. Now, Hashimoto's thyroiditis is an autoimmune disease, meaning that the immune system goes rogue and starts attacking our own follicular cells in the thyroid. The exact trigger for this response is unknown, but there does seem to be a genetic component. For example, mutations in specific human leukocyte antigen genes, called HLA-DR3 and HLA-DR5, are associated with developing Hashimoto's thyroiditis. Due to these susceptibility genes, immune cells sometimes aren't clever enough, and they end up confusing normal antigens from the thyroid gland with antigens of foreign invaders, like viruses, just because they look similar. This process is called molecular mimicry, because from the perspective of the immune cells, a host protein is mimicking a foreign protein. When our own protein triggers an immune response, that protein is called an autoantigen. So these autoantigens get picked up by antigen-presenting cells and get carried to the nearby lymph node to activate CD4 positive T helper cells. T helper cells stimulate the B cells in the lymph node to start proliferating and differentiate into plasma cells, which produce specific autoantibodies against these autoantigens. In Hashimoto's thyroiditis, these plasma cells and T helper cells enter the circulation and reach the thyroid gland. Once there, plasma cells make antibodies against thyroid peroxidase, thyroglobulin, or TSH receptors. These autoantibodies bind to and block those targets, which gets in the way of normal thyroid function. In addition, they act like a tag on the follicular cells that have these proteins, so that they can be targeted and destroyed by natural killer or NK cells. Meanwhile, CD4 positive T helper cells produce inflammatory cytokines, like interferon gamma, which attract macrophages into the thyroid gland and then cause damage to the follicles. These cytokines also attract another type of T lymphocytes, called CD8 positive cytotoxic T cells. Those CD8 positive cytotoxic T cells directly target and destroy thyroid follicular cells. Initially, the destruction of follicular cells leads to T3 and T4 getting spilled out into the blood, creating a transient hyperthyroid or thyrotoxic state, often called hashitoxicosis. But as the thyroid gland gets more and more damaged, thyroid hormones diminish. The hypothalamus and pituitary gland respond by increasing their TRH and TSH production, but eventually the thyroid becomes too damaged to produce enough thyroid hormones. Long-term inflammation causes follicular cells to change into what are called Hürthle cells, which are enlarged cells with an eosinophilic or pink and granular cytoplasm. Meanwhile, the colloid gets depleted and follicles atrophy, or get smaller. What forms in between them are clusters of lymphocytes, particularly B cells, called germinal centers. These germinal centers form outside of lymph nodes, where they're usually found, and are in the thyroid gland tissue itself. In rare situations, these B cells might turn cancerous, giving rise to a B cell lymphoma of the thyroid gland. In any case, though, all this chronic inflammation also causes connective tissue to build up around these atrophic follicles. This increased amount of connective tissue, along with the extensive immune cell infiltration, causes the gland to enlarge. In other words, as the disease progresses, the thyroid gland consists of more and more immune cells and connective tissue, and less functioning thyroid cells. Symptoms of Hashimoto's thyroiditis usually starts in the hypothyroid phase and are directly related to low T3 and T4 levels. Individuals often have a goiter, meaning that their thyroid is enlarged and sometimes has nodules or lumps, which can sometimes press on the trachea, causing voice hoarseness, or on the esophagus, causing difficulty swallowing. The decreased metabolic rate could cause individuals to get tired easily, as well as feel weak and cold, have constipation, and rapid weight gain even without any change in diet or exercise. Typically, the heart rate and respiratory rate slow down as well. The skin can become dry and rough because there's less sweat secretion, and the hair and nails become brittle and can sometimes fall off. Elevated prolactin levels from the increased thyrotropin-releasing hormone could also cause problems like menstrual abnormalities and galactorrhea, which is a milky nipple discharge, as well as infertility. In severe cases, myxedema develops, meaning that there's increased deposition of various proteins and mucopolysaccharides in the upper skin layers, leading to edema or swelling, in particular around the eyes, hands, and feet. Finally, in the rare case of a thyroid lymphoma, there's an extremely fast-growing goiter, which compresses the trachea and the esophagus even more. Sometimes the lymphoma might also spread to the nearby lymph nodes, causing them to enlarge, or to various other organs all over the body, like the lungs and the liver. Diagnosis of Hashimoto's thyroiditis is usually based on a combination of low serum levels of free thyroid hormones and increased TSH levels, with high levels of the associated autoantibodies, mainly antithyroid peroxidase and antithyroglobulin antibodies. Fine needle aspiration should be used to get a biopsy when thyroid lymphoma is suspected. Treatment of Hashimoto's thyroiditis typically requires lifelong thyroid hormone replacement, mainly with levothyroxine. For individuals with a really large goiter compressing the airways or the esophagus, or if there's suspicion of a lymphoma, then surgical removal might be needed. Alright, as a quick recap, Hashimoto's thyroiditis is an autoimmune disorder in which the thyroid gland is gradually destroyed, and this results in hypothyroidism and an increased risk of thyroid cancer. With postpartum thyroiditis, postpartum means after birth. Thyroid refers to the thyroid gland, and itis means inflammation. So postpartum thyroiditis is an inflammation of the thyroid gland that women experience after giving birth. Now, normally the hypothalamus, which is at the base of the brain, secretes thyrotropin-releasing hormone, or TRH, into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary gland. The anterior pituitary then releases thyroid-stimulating hormone, aka thyrotropin, or just TSH. TSH stimulates the thyroid gland, which is a gland found in the neck that looks like two thumbs hooked together in the shape of a V. If we zoom into the thyroid gland, we'll find thousands of follicles, which have a sticky substance called colloid, which sits within follicular cells. Follicular cells convert the protein thyroglobulin into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and the majority is bound to circulating plasma proteins, with only a small amount of T3 and T4 traveling unbound in the blood. Ultimately, these two hormones get picked up by nearly every cell in the body, and once inside the cell, T4 is mostly converted to T3, at which point it can exert its effect. T3 speeds up the basal metabolic rate. So as an example, they might produce more proteins and burn up more energy in the form of sugars and fats. It's like the cells are kind of in a frenzy. T3 increases cardiac output, stimulates bone resorption, which thins out the bones, and activates the sympathetic nervous system, which is a part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase is like getting a boost to fight off a hungry predator, or to stay warm during a snowstorm, or both. Thyroid hormones are also involved in a number of other things, like controlling sebaceous and sweat gland secretion, hair follicle growth, and regulating proteins and mucopolysaccharide synthesis by skin fibroblasts. And for all this to work right, the levels of thyroid hormones have to stay within a normal range. To do that, the body uses negative feedback, which means that low levels of thyroid hormones tell the hypothalamus and pituitary gland to increase their secretion of TRH and TSH, respectively. More TRH increases TSH production in the pituitary, and the thyroid gland gets more stimulation to make thyroid hormones. And eventually T3 and T4 levels go back up to the normal range again. In postpartum thyroiditis, a woman typically has a pre-existing autoimmune thyroiditis, like Hashimoto's thyroiditis. But it's usually pretty mild, so they might not have any symptoms. When she gets pregnant, though, there are a lot of physiologic changes, and one of them is to dampen the immune response, probably to stop the immune system from reacting to the presence of a baby that makes new proteins because of the father's DNA. Then after birth, the immune system returns to its normal level of activity, and that change can sometimes aggravate the pre-existing autoimmune thyroiditis. Ultimately, the reason our immune system might attack the thyroid is molecular mimicry, where thyroid cell antigens look so similar to antigens of foreign invaders, like viruses, the immune cells actually confuse the two. Anytime this happens, the body's cells earn the name of autoantigens. When it happens, the autoantigens, in this case from the thyroid cells, get picked up by antigen-presenting cells and delivered to a nearby lymph node, activating CD4 positive T helper cells. T helper cells stimulate the B cells in the lymph node to start proliferating and differentiate into plasma cells, which are able to produce specific autoantibodies against these autoantigens, like thyroid peroxidase, thyroglobulin, and TSH receptors. These autoantibodies bind to and block those targets, preventing normal function of the thyroid. In addition, they act like a tag on the follicular cells that have these autoantigens, so that they can be targeted and destroyed by natural killer cells. Meanwhile, CD4 positive T helper cells produce inflammatory cytokines, like interferon gamma, which attract macrophages into the thyroid gland, which go on to cause damage to the follicles. These cytokines also attract another type of T lymphocytes, called CD8 positive cytotoxic T cells. CD8 positive cytotoxic T cells directly target and destroy thyroid follicular cells. Now, initially, the destruction of these follicular cells leads to T3 and T4 getting spilled out into the blood, creating a transient hyperthyroid or thyrotoxic state. But as the thyroid gland gets more and more damaged, the colloid gets depleted over time, and follicles atrophy or get smaller. This leads to decreased T3 and T4, and cause hypothyroidism. In any case, though, all this inflammation also causes connective tissue to build up, leaving less space for the functional thyroid cells. In most people with postpartum thyroiditis, the thyroid normally recovers within a year of giving birth. But in some unlucky mothers who experience the hypothyroid stage, the thyroid never recovers, leaving them with a chronic case of hypothyroidism. Postpartum thyroiditis usually causes a painless goiter, which is an enlarged thyroid gland. Initially, destruction of the thyroid cells release thyroid hormone and causes hyperthyroidism. In that phase, the body has an increased metabolism, which can cause weight loss, palpitations, tremors, anxiety, or heat intolerance. Typically, this will start off a few months after delivery and last up to 8 weeks. Then there's the hypothyroidism phase, where the body has a decreased metabolism, which can cause a lack of energy, constipation, dry skin, or cold intolerance. Typically, this can last up to 6 months. The diagnosis of postpartum thyroiditis can be confirmed with thyroid function tests to establish whether someone is in the hyperthyroid or hypothyroid phase, and can be confirmed by looking for anti-thyroid peroxidase antibodies. Most of the time, postpartum thyroiditis doesn't require treatment, But sometimes beta blockers like propranolol can help with symptoms like palpitations and tremors. And in hypothyroidism, thyroid hormone replacement can help as well. Alright, as a quick recap. Postpartum thyroiditis is an inflammation of the thyroid gland that happens in a woman a few months after she's given birth. It's often due to an aggravation of a pre-existing autoimmune thyroiditis. Initially, damage to the thyroid gland can result in hyperthyroidism, but later on, the loss of healthy thyroid tissue can result in hypothyroidism. In most cases, thyroid activity returns to normal after about a year.
With Riedel's thyroiditis, thyroid refers to the thyroid gland, and itis means inflammation. So, Riedel's thyroiditis is a condition where there is inflammation of the thyroid gland, which slowly causes fibrous tissue to replace the normal thyroid tissue. The condition is named after the German surgeon Dr. Bernhard Moritz Karl Ludwig Riedel, who first described it. Normally, the hypothalamus, which is located at the base of the brain, secretes thyrotropin-releasing hormone, known as TRH, into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases a hormone of its own, called thyroid-stimulating hormone, thyrotropin, or simply TSH. TSH stimulates the thyroid gland, which is a gland located in the neck that looks like two thumbs hooked together in the shape of a V. If we zoom into the thyroid gland, we'll find thousands of follicles, which are small hollow spheres whose walls are lined with follicular cells and are separated by a small amount of connective tissue. Follicular cells convert thyroglobulin, a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. But only a small amount of T3 and T4 will travel unbound into the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted into T3, and then it can exert its effect. T3 speeds up the basal metabolic rate, so as an example, they might produce more proteins and burn up more energy in the form of fats and sugars. It's as if the cells are in a bit of a frenzy. T3 increases cardiac output, stimulates bone resorption, thinning out the bones, and activates the sympathetic nervous system, the part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase can be really useful when you need a boost to get through the final rounds of a sporting competition, or to stay warm during a snowstorm. Meanwhile, thyroid hormones are involved in a number of other things, such as normal function of sebaceous and sweat glands, growth of hair follicles, and regulation of the synthesis of proteins and mucopolysaccharides by skin fibroblasts. It's not entirely clear why, but sometimes the immune system begins to attack certain organs and tissues. More specifically, there's a pattern of autoimmune diseases that involves T cells and plasma cells that overproduce a specific type of IgG antibody called IgG4. It goes rogue and attacks multiple organs like the thyroid, pancreas, lacrimal or tear glands, and salivary glands. When the thyroid is severely affected, it's called Riedel's thyroiditis. In Riedel's thyroiditis, we don't know what IgG4 antibodies do exactly, but we do know that the T cells release cytokines that attract macrophages and neutrophils, which in turn damage the thyroid follicles. Over a period of weeks to months, the loss of healthy thyroid tissue eventually leads to hypothyroidism. The cytokines also activate fibroblasts, which are cells that normally reside in the tissue between follicles. Fibroblasts produce fibrous connective tissue, and when they're activated chronically, they generate so much protein that the thyroid gland simply fills up with dense fibrous tissue, making it large and hard. The enlarged thyroid gland is called a goiter. What sets Riedel's thyroiditis apart from other autoimmune thyroid inflammations, like Hashimoto's thyroiditis, is that the fibrosis doesn't stop with the thyroid gland. The inflammation destroys tissue planes and extends beyond the thyroid capsule. Once the fibrosis sets in, the nearby structures like the parathyroid glands, trachea, and muscles, nerves, and blood vessels of the neck can all fuse together. The neck structures all join into one solid fibrous mass, like an iron collar. The most common symptom of Riedel's thyroiditis is a goiter that's about as hard as a rock, and it may be on one side or both sides of the neck. The goiter can put pressure on surrounding structures, like nearby airways, which causes shortness of breath, or on the esophagus, which causes dysphagia or difficulty swallowing. It can also put pressure on the recurrent laryngeal nerves supplying the vocal cords, which can make the voice hoarse. Hypothyroidism can cause symptoms like a lack of energy, constipation, dry skin, or cold intolerance. Diagnosis of Riedl's thyroiditis typically involves low thyroid hormone levels and increased TSH levels. Radiological imaging with an ultrasound, CT scan, or an MRI might show an enlarged thyroid gland which may compress surrounding structures. A tissue biopsy usually shows lots of fibrous tissue along with a large number of T cells and IgG4 antibody-producing plasma cells. Treatment of Riedl's thyroiditis includes corticosteroids to suppress the immune system and thyroid hormone replacement to correct hypothyroidism. Surgery may be done to remove a goiter, but it can be difficult if it's spread to nearby structures. Alright, as a quick recap, Riedl's thyroiditis results from T cells infiltrating the thyroid gland and IgG4 antibody-producing plasma cells generating antibodies that attack the thyroid gland. Typically, there's a large goiter that can put pressure on nearby structures like the trachea, esophagus, and recurrent laryngeal nerves, as well as symptoms of hypothyroidism, like weight gain and cold intolerance. Subacute granulomatous thyroiditis, also known as de Quervain's thyroiditis, belongs to a group of disorders featuring inflammation, or itis, of the thyroid gland. This inflammation is granulomatous, meaning there are aggregations of immune cells, mainly activated macrophages that form tiny nodules within the thyroid gland. Subacute implies that it's somewhere between acute and chronic, typically developing after an acute event like a viral infection. Normally, the hypothalamus, which is located at the base of the brain, secretes thyrotropin-releasing hormone, known as TRH, into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases a hormone of its own, called thyroid-stimulating hormone, thyrotropin, or simply TSH. TSH stimulates the thyroid gland, which is a gland located in the neck that looks like two thumbs hooked together in the shape of a V. If we zoom into the thyroid gland, we'll find thousands of follicles, which are small hollow spheres whose walls are lined with follicular cells and are separated by a small amount of connective tissue. Follicular cells convert thyroglobulin, a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. But only a small amount of T3 and T4 will travel unbound into the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted into T3, and then it can exert its effect. T3 speeds up the basal metabolic rate, so as an example, they might produce more proteins and burn up more energy in the form of fats and sugars. It's as if the cells are in a bit of a frenzy. T3 increases cardiac output, stimulates bone resorption, thinning out the bones, and activates the sympathetic nervous system, the part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase can be really useful when you need a boost to get through the final rounds of a sporting competition, or to stay warm during a snowstorm. Meanwhile, thyroid hormones are involved in a number of other things, such as normal function of sebaceous and sweat glands, growth of hair follicles, and regulation of the synthesis of proteins and mucopolysaccharides by skin fibroblasts. Now, subacute granulomatous thyroiditis is typically triggered by a viral infection of the upper respiratory system. For example, adenovirus, mumps, measles, or Coxsackie virus. Sometimes these viruses spread to the thyroid gland and target the thyroid cells, and when they get in and infect these cells, they can cause the thyroid cells to present weird and abnormal proteins on their MHC class I molecules. Soon, immune cells, particularly CD8 positive T cells and antigen-presenting cells like macrophages, rush into the thyroid tissue. When the CD8 positive T cells identify the abnormal proteins on the MHC class I molecules, they typically destroy the thyroid cells. As these thyroid cells die, they spill out viral antigens, as well as some of their own cellular antigens like thyroid peroxidase, thyroglobulin, or TSH receptors. And while macrophages try to clean away those viral remnants, they sometimes pick up the thyroid antigens as well. Next, these macrophages carry both viral and thyroid self-antigens to a nearby lymph node to activate CD4 plus T helper cells. T helper cells secrete inflammatory cytokines like interferon gamma, which help activate more macrophages. Meanwhile, other cytokines like interleukin 2 stimulate the B cells in the lymph node, which makes them proliferate and differentiate into plasma cells, which produces not only specific antibodies against the virus, but also autoantibodies against those self-antigens. Now, all of these antibodies, as well as the activated macrophages, enter the circulation and reach the thyroid gland. Once there, some of the antibodies target the viral infected cells, but some also bind to thyroid peroxidase, thyroglobulin, or TSH receptors of the surrounding healthy cells. These autoantibodies not only block normal thyroid function, but also tag the follicular cells for further destruction by activated macrophages, and for them, that's not a good sign. Some of the macrophages join together to form giant cells with multiple nuclei, which is why sometimes this condition is called giant cell thyroiditis. Often, these activated macrophages, either as single cells or as multinucleate giant cells, along with some lymphocytes, organize themselves into granulomas. These are basically small aggregates of macrophages surrounded by giant cells in a rim of lymphocytes. Ultimately, the result is that the thyroid gland ends up getting simultaneously destroyed by both the virus as well as by its own immune cells. At first, as the follicles get destroyed, T3 and T4 spill out into the blood, creating a transient hyperthyroid or thyrotoxic state. Excess T3 and T4 reaches every cell in the body and speeds up its metabolism. Because of the high levels of T3 and T4, the pituitary gland decreases its TSH production. The good thing is that the process is self-limited in most cases, meaning that as soon as the viral infection is over, inflammation subsides on its own, so the thyroid follicles start repairing themselves and restoring their normal function. This might take 6 to 8 weeks or a bit longer, but recovery is nearly always complete. In rare cases, the damage can't be repaired. In those situations, the loss of thyroid tissue causes a hypothyroid state. Symptoms of a subacute granulomatous thyroiditis usually begin several days to a few weeks after a viral illness, such as pharyngitis. The most prominent sign is an enlarged, painful thyroid gland, which can sometimes press on the esophagus, causing dysphagia, which is difficulty swallowing. During the hyperthyroid or thyrotoxic state, the increased metabolic rate could cause individuals to feel hot and sweat a lot, have diarrhea, and rapidly lose weight even without any change in diet or exercise. After about 6 to 8 weeks, however, thyroid function typically goes back to normal, so symptoms disappear completely. In the rare case of a progression to a hypothyroid state, the decreased metabolic rate causes a person to feel cold and weak, develop dry and rough skin, have constipation, and rapidly gain weight, again without any change in diet or exercise. Diagnosis of subacute granulomatous thyroiditis is usually based on seeing an initial hyperthyroid phase where T3 and T4 are high and TSH is low. While these most commonly go back down to normal or rarely progress to a hypothyroid phase with low T3, T4, and high TSH. Inflammatory markers like erythrocyte sedimentation rate and C-reactive protein are also typically elevated. Since subacute granulomatous thyroiditis generally resolves on its own, treatment requires supportive care with pain medications such as non-steroidal anti-inflammatory drugs, but close monitoring with thyroid function tests is important so that if hypothyroidism develops, thyroid hormone supplements can be administered. Alright, as a quick recap. Subacute granulomatous thyroiditis is a self-limited inflammatory condition of the thyroid gland that commonly occurs after an upper respiratory tract infection. It presents as a transient painful enlargement of the thyroid gland with hyperthyroid signs, and in rare occasions, progresses to hypothyroidism.
The thyroid gland is an endocrine gland in the neck that produces thyroid hormones. If the cells of the thyroid gland start to divide uncontrollably, then that's considered a thyroid cancer. Normally, the hypothalamus, which is located at the base of the brain, secretes thyrotropin-releasing hormone, or TRH, into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases a hormone of its own, called thyroid-stimulating hormone, thyrotropin, or just TSH. TSH stimulates the thyroid gland, which is a gland found in the neck that looks like two thumbs hooked together in the shape of a V. The entire gland is covered in a thin, tough membrane called the fibrous capsule. If we zoom into the thyroid gland, we'll find thousands of follicles, which are small, hollow spheres whose walls are lined with follicular cells, and are separated by a small amount of connective tissue. Follicular cells convert thyroglobulin, which is a protein found in follicles, into iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, at which point it can exert its effect. T3 speeds up the basal metabolic rate. So as an example, they might produce more proteins and burn up more energy in the form of sugars and fats. It's kind of like the cells are in a bit of a frenzy. T3 increases cardiac output, stimulates bone resorption, which thins out the bones, and activates the sympathetic nervous system, which is the part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase is like getting a boost to fight off a zombie, or to stay warm during a snowstorm. Thyroid hormones are also involved in a number of other things, like controlling sebaceous and sweat gland secretion, hair follicle growth, and regulating proteins and mucopolysaccharide synthesis by skin fibroblasts. The thyroid is also made up of parafollicular or C cells, which are near the follicles. These cells produce calcitonin, which is a hormone that lowers blood calcium levels by inhibiting osteoclasts. Osteoclasts are bone cells that break down bone tissue, which frees up the calcium to enter the bloodstream. Calcitonin also inhibits renal tubular cell reabsorption of calcium, allowing the calcium to be excreted in the urine. DNA mutations can cause thyroid cells to become cancerous. For example, a mutation might change a proto-oncogene like RET and BRAF, which are genes that code for proteins that promote cell growth and proliferation, into oncogenes. That would mean that the proteins force the cell to be stuck in the on position, always dividing, and that causes the thyroid cell to turn into a tumor. There are other genes called tumor suppressors, like PTEN, that normally slow down cell division, or make cells die if they divide uncontrollably. DNA mutations might also turn off tumor suppressor genes, which allows thyroid cells that try to divide uncontrollably to go unchecked. Over time, a thyroid cell that divides uncontrollably will lead to a lump of cells within the thyroid, called a nodule. Most often, nodules are non-functional, so they don't produce thyroid hormones, and these are called cold nodules. Now, there are three main types of thyroid cancer: differentiated, medullary, and anaplastic. In differentiated thyroid cancer, the cancer arises from follicular cells, and it's known as differentiated because the cancer cells look and act like normal thyroid cells. Within the differentiated thyroid cancers, there are three groups: papillary, follicular, and Hürthle cell carcinoma. The first group, papillary carcinomas, represents the most common form of thyroid cancer and is associated with RET and BRAF gene mutations, as well as exposure to ionizing radiation during childhood, as was seen in kids near the Chernobyl nuclear power plant accident. The name papillary refers to the fact that these tumors have finger-like prolongations of follicle cells known as papillae, that tend to grow slowly towards nearby lymphatic vessels and invade nearby lymph nodes in the neck. Under the microscope, the nuclei of papillary carcinoma cells contain very few proteins and a small amount of DNA, and that gives the appearance of an empty nucleus, sometimes called an orphan Annie nucleus, based on an old famous cartoon character. Another feature are psammoma bodies, which are calcium deposits within the papillae. The second type, follicular carcinomas, also known as follicular adenocarcinomas, represent the second most common form of thyroid cancer. This type of thyroid cancer is more frequently associated with countries where people have low dietary iodine, but is also associated with the activation of RAS oncogene or the deactivation of the tumor suppressor gene PTEN. In follicular carcinomas, the tumor develops from the follicular cells and grows until it breaks through the fibrous capsule. From there, follicular carcinomas can invade into nearby blood vessels and spread to other parts of the body like the lungs, liver, bone, and brain. But interestingly, they don't typically invade nearby lymph nodes. The third type, Hürthle cell carcinoma, is a rare type of cancer and it's considered a variant of follicular carcinoma. A tumor can often cause immune cells to attack it, causing inflammation. Follicular cells in the thyroid adapt to cellular stress like inflammation by becoming Hürthle cells. They do so by increasing the production of mitochondria, which fills up their cytoplasm and gives it a granular appearance and stains pink. These cells are also seen in disorders like Hashimoto's thyroiditis, where the thyroid is also inflamed. Like in follicular carcinomas, Hürthle cells form neoplastic tumors that break through the fibrous capsule and invade via the bloodstream. So, moving beyond the differentiated thyroid cancers, there are the medullary thyroid carcinomas, which arise from C cells. There's a higher concentration of C cells in the upper one-third of the thyroid medulla, which is where these tumors usually arise. Most of the time, it forms because of a spontaneous mutation in the RET oncogene, and it's usually a single carcinoma in one lobe of the thyroid. But sometimes it can arise as part of an inherited mutation, like in familial medullary thyroid carcinoma, which runs in families. And in those cases, there can be multiple carcinomas across both lobes. It can also be associated with a hereditary condition called multiple endocrine neoplasia, or MEN, type 2A and 2B. In these conditions, one or more of the endocrine glands, like the thyroid gland, parathyroid gland, and adrenal gland, develop tumors. Under the microscope, medullary thyroid carcinoma is made up of spindle-shaped cells, which are called that because they're long and skinny, like a spindle that's used to spin fibers into thread. C cells in the tumors make excessive amounts of calcitonin, which deposits between the C cells. Calcitonin is a protein hormone, so as the calcitonin deposits, the resulting clumps of protein stick together and form fibrous deposits called amyloids around the C cells. Tumors formed by C cells can also release other hormones, like serotonin and vasoactive intestinal peptide, which can cause increased gastrointestinal motility. Finally, there are the anaplastic thyroid carcinomas. These are a rare form of thyroid cancer, named for having altered cells that don't look anything like normal thyroid cells. It might be that these tumors derive from an existing papillary or follicular cancer, where the cells mutate even more and become unrecognizable. Under the microscope, anaplastic carcinomas typically contain spindle-shaped cells as well as pleomorphic giant cells, which are enlarged cells that vary in shape. These cancers are the most aggressive compared to the other thyroid cancers. They often grow beyond the fibrous capsule of the thyroid gland and invade nearby structures. Most often, the first sign of thyroid cancer is a solitary, painless nodule in the thyroid gland. Typically, the hard and immovable nodules are more likely to be tumors. If the tumor gets too big or invades the larynx or esophagus, it can cause hoarseness and trouble swallowing. Thyroid cancers are non-functional, so they usually don't present with signs of hyper or hypothyroidism. In medullary thyroid carcinoma, release of vasoactive intestinal peptide leads to diarrhea, and increased serotonin levels leads to flushing of the skin. The diagnosis of thyroid cancer often starts with imaging studies, like a thyroid ultrasound, which can help identify a thyroid nodule. Calcitonin levels are usually elevated in medullary thyroid carcinomas. A radioiodine scan can also be useful, and that's where radioactive iodine is ingested and taken up by cells that make thyroid hormone. Usually, thyroid tumors don't make thyroid hormone, so they're cold nodules. The best way to be sure, though, is to use fine needle aspiration, where a thin needle is used to take small tissue samples from the thyroid nodule in order to identify the type of tumor. The treatment of thyroid cancer depends mostly on the type of cancer and how it's spread. Options include partial thyroidectomy, where the affected part is removed, or total thyroidectomy, where the entire thyroid is removed, followed by thyroid hormone replacement. All right, as a quick recap, thyroid cancer is a cancer that forms in the thyroid gland, and it arises from either follicular cells or C cells. There are 3 main types of thyroid cancer: differentiated, medullary, and anaplastic. All the differentiated types arise from follicular cells, and the most common type is papillary carcinoma. Medullary carcinomas arise from the C cells of the thyroid, which produce calcitonin. Diagnosis usually starts with a thyroid ultrasound, and it's confirmed with a fine needle aspiration. Treatment consists of a total or partial thyroidectomy.
Hi guys, I'm Pauline. I'm one of Osmosis's newest illustrators. You might be able to tell from my accent I'm from the UK, reporting to you from Edinburgh in Scotland right now. So I hope you enjoyed this video on thyroid cancer and that you learned a lot. As always, we love hearing your comments and feedback. So if you have anything that you'd like to share with us, may it be from questions to requests to even just why you're watching our video, please do let us know in the comments. We absolutely love it. And if you want to find out more, if you're studying medicine, for example, do check out our other content at osmosis.org. We've got loads of other videos that we don't release on YouTube, as well as related questions and flashcards that you might find useful to test yourself. So that's all from me. Bye guys!